This is Impact Healthcare, people and strategies that are disrupting the health benefits industry. And now, here's your host, healthcare benefits industry expert and the originator of the transparent health benefits movement, Lester Morales.
Welcome back to another episode of the Impact Healthcare podcast. And, when your guest comes on and says something about your small shirt, this is going to be a good conversation. A guy who likes to get after it fitness-wise, like I do, Dr. Mark Testa. Welcome to the Impact Healthcare podcast. And for the people that don't know you, give us a little bit of an introduction to you and your great company.
Great. Thank you, Lester. Great to be here. I'm excited to be here. Real quick, I'm a chiropractor and acupuncturist, still see patients, spent the majority of my career in medicine, in orthopedic care, taking care of patients that way. I'm currently still seeing patients 2 half days, but my full-time gig is with Regenexx. Regenexx is a orthopedic surgery avoidance program. We're using patients' own cells, bone marrow concentrate, and blood platelets, platelet-rich plasma, to help people avoid elective orthopedic surgeries using a needle-based procedure.
Mark, you decided to go down the road of medicine for some reason, something when maybe we were a child. There, I feel like everybody got to where they are, especially when they're as passionate as you, because of some reason. What's that why? What's that thing that fires you up?
Yeah, you know what? I was thinking about that recently. I remember when I was very young, just trying to soothe my mother. She was having some sort of difficulty, and couldn't have been more than 5 or 6. Really just trying to soothe her. And that's my earliest memory of trying to help someone who was suffering. And then, like you in 8th or 9th grade, I got into working out and started looking at the anatomy charts to see where the bicep was and where all these things were. And I just got excited by it. Like, man, you can do a lot without drugs and surgery, nutrition, working out, exercise. And that led me into chiropractic, which, is non-surgical, non-drug. And then it really continued to push me forward into Regenexx when I was working in a pain practice during the Purdue Pharma heyday. And we literally, in 1 quarter, had 4 opioid deaths in 1 quarter. And I remember seeing a lady on Friday, and I look on my schedule on Monday, and I was like, where's so-and-so? Oh, she died this weekend from an overdose.
Wow.
And that was a big, wow, we need better solutions. And a lot of the people we were treating had surgery failures, were in chronic pain, and all the docs really had was steroids and long-acting and short-acting opiates. And so I was like, man, we need better solutions than that.
Wow. I didn't even think about that correlation. So, orthopedic, MSK, right? Musculoskeletal, for those that aren't nerds like us. I'm looking at claims data this morning, speaking of nerds, and every group, and prepping for this, I knew we were talking. I was like, my gosh, every single group, MSK was at the top of their list. It was either second or third on every group. Number one, is that normal? So are most employers suffering from this? And the second thing is, why?
I nerd out and look at a lot of claims data too, and I consistently see it. 2 or 3. Sun Life just published their report, I think from 2024, it was number 2 behind cancer, with an increasing frequency and an increasing cost. So I think it's just, the body breaks down, it gets worn out, and it's not necessarily even industry specific, although you can certainly look at industries and say, yeah, they're going to wear out faster. We're active, we get injured, we have car crashes, we get hurt working out. Just the body, is not invulnerable to this. And then most people don't take care of it in a good way conservatively until it's like really at the end of the line. And now they're looking at some sort of surgical intervention. So it's just, body breaks down.
I think you're being nice and politically correct, but I think that one answer behind that too is the average person is infinitely heavier than they were, before, and that creates an issue as well. But I'll leave my soapbox about diet and exercise later. I want to draw myself as an example. I was a big wakeboarder in high school, college, post college. We all bought a boat together. It was an Aeronautique. It was like the Lamborghini of wakeboards. We used to meet at 7 o'clock in the morning. We'd board for 3 or 4 hours and then we'd go have fun. I practicing a move, my kneecap ends up on the wrong side of my leg, right? I have ACL, MCL, and PCL complete tears. Talk to me about, and maybe that's a bad example because it was too severe, but talk to me about kind of the progression because, to a hammer, everything looks like a nail, right? And I got to imagine that the majority of people go from, oops, I hurt myself. I go to an orthopedic. An orthopedic gets paid to do a surgery, not to prevent a surgery. That surgery is, in my case, $90,000 of billed charges. Talk to me about what happens in the Regenexx world.
So yeah, that kind of trauma is probably beyond what we could intervene on. But we do see a lot of people with partial ACL tears, right? Or it's not fully retracted. And we've published on this. They might come to us, maybe they've already tried conservative therapy, physical therapy, hopefully. It's not going to repair an ACL, but you can do pretty good for a long time with a partial tear. But those people who come to us with a partial tear or, again, one not fully retracted, when we put their bone marrow concentrate into that ACL, we can see it repair itself. The ACL has a natural sheath around it. So when you put cells in there, and you've got to use video x-ray, you got to be proficient at identifying the anatomical targets. When you put those cells in there, and over a few months, it will repair itself, and so we've seen that before and after MRIs multiple times. Replacing it is, the step if you can't do that, but replacing it changes the anatomy, it changes the biomechanics, it accelerates degenerative changes, and it is not uncommon to see 30 and early 40-year-olds needing a knee replacement after that sort of surgical intervention.
Yeah. I can tell you when it's gonna rain, because I remember, hearing older folks when I was a kid saying that stuff. I'm like, "Oh, it's just because 'cause you're old," and I can tell you for sure. So, you said a lot of big words there, but,
Yeah.
like, let's retract that. I tweaked my knee a little bit, right? It feels funny. I go to the orthopedic. Is this something that a patient is typically kind of saw an advertisement on the news and said, "Hey, doc, what about this, procedure?" Or how does somebody kind of start that process? I'm really curious.
So start that process with us or in general addressing.
Yeah, no, like how would somebody? Because naturally, again, they're gonna go to an orthopedic. The orthopedic doesn't necessarily get paid to not do the surgery. So I'm wondering, like, how does somebody get to know you? And then I want to dig into like that whole process.
So yeah, we get built into a self-funded plan, added
Okay.
as a service, paid as a claim. But we go out of our way to make sure because to your point, right? If they don't know about this and they bypass it, they're going to the surgeon, they're getting surgery. So we make a very proactive push to educate people. We send out benefit cards. Because if people don't know, they don't know. We educate them. We give every employer a web portal where they can look at our research, our outcome data. We've been doing this for 20 years, so we've got a lot of all that. Where our locations are. We give that so HR doesn't have to do that work. We do weekly educational webinars. I've done about 500 of them since COVID. And And so employees can sign up. They want to learn about it too. They have heard about it, to your point, like, if they follow athletics or they're just online looking for an alternative, they'll hear about it. And then we work with TPAs to get file feeds because, like you said, once you get hurt, maybe you got an MRI, and then maybe you got a steroid injection, and then maybe you got the knee gel. We know what's coming next. So we reach out to people and say, hey, Lester, by the way, we wanted to just let you know your employer has this benefit, and you can go learn more about it at regenexbenefits.com. And that's how we try to get in front of it. And when we do that, it works really well, and we get the appropriate amount of utilization out of this for an employer. 1 to 2% of the plan are going to be an appropriate candidate for this. Now, we have a whole candidacy grading and prior auth process that comes after that, but that's sort of how they find us.
So
Go ahead.
no, I was gonna say in that scenario, so like, I mean, obviously this is kind of one of those things that is a win-win-win, right? I'm assuming that the patient is out of work a significant less time, or there's less trauma. So like I could, go back. I mean, I was on crutches for 17 weeks, and I'll tell you, mentally, I've never really been a depressed guy, but you put somebody like me who can't, like, I remember the reason I started doing yoga is because I couldn't put my pants on because my brace was, locked my leg out and I couldn't even like get to my toes. So talk to me about the benefits all the way around, because this has to have some crazy stats in regards to lessening, out of work time and cost and all of that stuff. Let's take that 360.
Yeah, that's great. And to your point, like, right, a rotator cuff repair, 6 weeks off work, 6 to 12 months of really miserable rehab. And if you don't do it, you get frozen shoulder, and that average is about a year to get that back. Or you get manipulation under anesthesia to get that back, another procedure. So return to work is quick because it's needle-based. Most people get back to work literally in days, not weeks or months. Let's look at spine, one of our least expensive procedures, sort of contradictory to spine surgeries, right? Ours are $4,000 versus, depending what you get, 50 to 100 for a spine surgery. I just had a firefighter get a 2-level fusion, 2 to 3 months off of work. And he's going to have 6 to 12 months of rigorous rehab if he's going to get it back. And, there's a high failure rate with spine surgeries. So, you know, the return to work is really quick. Now, if you're a fireman and you got a treatment from us, you might not be back on the rig in 2 or 3 days, but you can get back to, light duty quickly. I had my 3 partial tears done on the rotator cuff 3.5 years ago, and I was back seeing patients in 5 days. I took the weekend off, but I'm not going to rip out a stitch or a staple, and I was back in the gym doing rehab within a week. So it is a lot quicker recovery. And, there's a lot of risk goes into surgery. People don't think about it, but I've been seeing patients for 35 years. Plenty of risk, not to mention an increase in overall systemic inflammation. And, none of that's good for you.
And in that scenario, I think, when I heard you say spine, I don't know that I realized the extent of the potential. Talk to me about the range of where you could do this service. So I was thinking, more of your easier joints, but spine's a big deal. Talk to us about the whole spectrum there.
Really everything from head to toe that would otherwise maybe show up in an orthopedic surgeon's office. But the 3 most common body parts are knees, people trying to avoid a knee replacement, which we can get using the techniques that we're using now, published with our data from our clinical research physician, Philip Hernegal, the first orthopedic surgeon to do this work in Europe in the 80s, 10 to 15 years of durability out of that.
Wow.
Number 2, and ACLs and meniscus, another one. Meniscus surgeries have 4 or 5 randomized control trials showing no more effectiveness than physical therapy or fake surgery. And we do a lot of those. And when you remove it, because that's what they're doing most of the time, they're not repairing the meniscus. There's a very narrow area that you can repair. When they remove it, the joint pressure increases, and so it wears out faster. You're going to end up with a knee replacement as your next step. Second most common body part, I call it 1A, is spine. Lumbar spine, number one, sciatica, all the disc problems, stenosis, all that. I think we have one of the best spine programs going because I'm a recipient of it. And I can tell you, it's made a huge difference, neck as well. And then the third most common is shoulder, rotator cuffs and labrums. And so, a lot of people with partial tears. I had 3 partial tears. I always like to show this because it's 3 years later and I got range of motion, full range of motion.
Wow.
And it's not going to continue to tear.
And, when you start thinking about, I mean, let's go back to that spine. Not only the cost, but like the stats on spine are terrible.
Yeah.
Like the success rate's terrible, but I look at that as somebody who did a significant amount of rehab when I tore my knee. you know, Rehab's 50-50, right? I gotta be a willing participant to do what I need to do. This approach lessens the risk on both ends. It lessens the risk on the actual surgery part, but it lessens a significant amount of risk that the patient, who probably isn't going to do all of the things that they need to get back, also do that. So, like, what talk to me about the procedure itself. Let's take a spine. Like, what happens and what's the rehab like? And like, talk to me about the details of that, because I'm fascinated with such a big body part with such severe, what you would normally get by the time somebody is in a situation to potentially have spine surgery. Like, they've probably been in pain for a long time. So, like, they didn't have to do all of this. They could have engaged you much sooner in the process. So talk to me about that.
Yeah, low back pain is the #1 disability in the world.
Yeah.
So
I'm feeling it right now.
there you go, right there. So let's just like use a herniated degenerative disc in the lumbar spine. We treat what's called the functional motor unit. So that vertebrae that's the problem is connected to the one above and the one below. In traditional pain, they treat the pain generator, one area, one side, one little thing with steroids. That's really all they have. And steroids just aren't good for the body. Try it once, but don't keep trying it if it didn't work. And so what we would do is use platelets, what we call platelet lysate. So we take the blood platelets out of the arm, which is similar to PRP, out of the blood, concentrate those, break them open. And when you break open platelets, they release a lot of growth factors. And so instead of a steroid epidural, putting it where the nerve is getting squashed, where it comes out of the spine, we would put platelets in there. And that is very soothing to the nerve. Now, it's not just the nerve getting squashed. The nerve travels with a blood vessel, an artery, a vein, and a lymphatic. And so those are all getting squashed. So that nerve's not even getting good blood supply. Platelets help new blood vessel formation around there. And I think that's one of the big reasons people get so much relief in that area. But we don't stop there. We treat the ligaments as well, above and below, because as that disc is thinning, right, the ligaments, which were tight here, are now loose because they're slack in them. And so everything's moving more than it should. And so you can tighten those up with PRP, platelet-rich plasma. And so we would treat above and below all those ligaments that are stabilizers. Then also the joints are approximating each other as the disc is thinning. And so those are becoming irritated and even hypertrophied. They're growing, they're getting bigger. And when they're getting bigger, they're taking up space. And that nerve has now got less of a hole to escape out of. So we put platelets in there to help calm down the inflamed joint. And then we even go a step further because probably 95% of people with low back pain have multifidus muscle atrophy. That's one of the main stabilizers in the spine. And we would put platelets into that. And so here's a great example. I referred a friend, she's in her 70s, they want to do a 5-level fusion. Worked at Ohio State, saw her MRI. I was like, this is bad. But a 5-level fusion is not going to help you. And so I talked to her yesterday, I wanted to follow up. It's been about 2 months, and her daytime pain is gone. She's still got butt pain at night, from the sciatic, which but is getting better and less frequency and intensity. So we usually see spine really resolve and do well. I was just looking at we're looking at our failure rate data right now and revising that. But average of patients that went on to have surgery after our spine at 4 years, 1.9%.
Wow.
Quite low. It works really, really well. And so, yeah, what I saw in the pain practice was, all right, let's do some PT, let's do some chiro, let's try some acupuncture, let's do some epidurals, let's do an ablation and burn the nerves, which are sensing the pain. And then when that doesn't work, we'll get a surgical consult. You may or may not be a good candidate. If you are, we might try to do something minimally invasive like a discectomy. Maybe we'll do a laminectomy. Maybe it's so bad we need to fuse it. But if and when those don't work, you end up in the pain clinic. And the pain clinic's got opiates. And that's it. You're done. And I've seen that kind of thing break up families, get people, not able to go back to work. It's a bad avenue to go down just in traditional spine care. It's not always effective for everyone.
And if we take those, so minimal from the evasive part, right? Like anytime you do a surgery, it's super bad, right? When you start thinking about that, so how are well, I guess first question, are people doing this from a workers' comp standpoint as well?
That's a great question. So every state has different work comp laws. That is
Yeah.
the number one problem. I know I do work comp here in Colorado, so we do use it, but not in the spine and not Regenexx. They farm it out to other people, and they're doing mostly extremities. Tennis elbow works great. We've identified a couple good providers that can do that. So some. Now, I did go to a work comp conference a couple years ago. I'm going to sound like a jerk. They're in the 90s when it comes to this. I was done there in 5 minutes after I talked to the main TPAs, and I was like, all right, I'm done. They're not even that. This is not even on their radar.
It's so funny because, like, to me, like, when you start thinking about the buzzwords and workers' comp and PNC, right? Risk management and risk mitigation and loss control. Well, like, the cheapest, knee surgery, knee replacement's the one that never happened. The second one is the one that you prevented. So it seems like that. So anyway, that was more the curious nerd in me. Your your advisors and the employer plans that you feel are doing this right, are they requiring this before a surgery is able to be pre-authorized? Are they incentivizing it? How are people building it in the plan? Because just like anything else cool that we put into plans, if your doc tells you to go do something, 9 out of 10 times the patient is going to go do it and doesn't ask questions. But this is such a middle step that seems so good. Like, how is it best put in these types of plans?
So yeah, we've been doing this 10 years in the self-funded space with close to 3,000 employers, but no one likes to be told what to do. So there have been a few employers who said, you got to you got to go for a consult before a joint replacement or a spine surgery. That just makes people upset. So we don't really recommend that. Definitely not in the first year because, again, our utilization strategy can get in front of it. There is a lot of incentives. And so with a just traditional PPO, a lot of employers make it free because number one, they're going to save up to 70%. Our validation institute is 49% saving. So they're already saving a lot of money. No facility fee, no anesthesia. Big savings already.
And
Others,
those are just hard dollar costs. That's not actually any soft dollar costs,
right?
time back to work and that kind of stuff. That's just hard dollar.
Yeah. And then other employers with the high deductible health plan, I've seen lower the deductible to the IRS minimum for Regenexx. They're not opening the whole plan up to that. So those incentives really make a difference.
Interesting. Interesting. And if there's medical management or some sort of advocacy service, Are they intervening too? Somebody's calling to ask about orthopedics. Are they saying, "Hey, did you know your plan has this, tool in it?" Is that another area of education and catch?
That is another area of education and catch. Some are better than others and catch
Sure.
it better. There's always turnover. I've trained a lot of people. We give them all the material, educational material to use. Even with those, we still do our utilization, our own process, because we just know that works. There are some digital physical therapy, right? Because we want to work with them too, where even we have APIs built with them because the employer's like, we want you to see who's getting PT. So they don't leave there and just go straight to the surgeon.
Right.
So we
Right.
try to catch it every way we can because, to your point, like if it's somebody says go here, they go there and don't question anything.
Yeah. What about healthcare facilities themselves? Because there's a side of me that's like, hey, do the right thing, and we might be singing "Kumbaya" next to the campfire, and then there's another side of me that says, well, no, a facility gets paid to do the things in the facility. How has that been in maybe the like, what is an orthopedic surgeon? What does a hospital think of this stuff? Is it a stay out of my cookie jar? Is it like, no, I get it. I'm seeing enough patients. What are your thoughts there?
So a couple thoughts on that. The orthopedic surgeons 5 years ago were like, stay away.
Right.
But a third of people who go to an orthopedic surgeon are not going to get surgery today. They just don't want it, right? And a third are not candidates. And so they can only operate on a third. And no kidding, they'll see 60 patients a day to find that third. And so people were walking out their office looking for solutions. They had to join it. They had to bring somebody in to do this. Again, not Regenexx, but they had to. They were losing patients. So they might not love it, but they had to do it for business purposes. That said, we have two hospitals that employ a Regenexx doc. I mean, they're not our doctors. They license our intellectual property, but we have one in Ohio who's been offering it to their employees, part of their employee benefit plan and all their other verticals for 10 years. So they get it because it's still their money, even though they employ surgeons.
On that side, I was like, it makes sense on their own employee plan because that's an expense over here. But on the revenue side is an interesting conversation.
And we just added one in Louisiana. So, and we're talking to more and more of them every day because they're self-funded. And so they get it. Like, yeah, this makes sense for us. And there's plenty of data on it. If you're willing to open your eyes and look at it.
Are there any, I don't know why this popped in my head. Are there any, religious things? I know some religions don't like, when you're messing with bloods and platelets and things. Are there any type of in that scenario?
Yeah, what is it?
I think it's Jehovah's Witness, right?
Thank you. Yes.
Yeah.
I talked to an advisor this year who's a Jehovah's Witness, and he asked me about that, and he didn't confirm or deny that there was a problem with doing your own blood platelets that way. So I don't know the right answer for that.
I don't know whether it popped in my head. It was an interesting question. So I'm trying to think why wouldn't, right? If you're an employer, this doesn't cost them anything outside of like, hey, when somebody uses it, but when somebody uses it, theoretically, they're going to use another service. So it's not a binary thing. It's not like they were going to spend 0, now they're spending 1.
Right.
They were going to spend 1. It's just how are they going to spend 1? Is that a fair way of looking at it?
Very accurate.
And, let's take an inexpensive let's go back to that meniscus. A meniscus build charge is still going to be over $20,000, yeah?
Yeah.
And so let's say 50% discount, plan's going to pay 10. That's going to hit an employee's out of pocket max. So employees out $5,000, employers out $10,000. This could have been what? What's a meniscus cost with you guys roughly? I mean, just ballpark.
5,000.
So employee
maybe
pays
less.
0, employer saves 50%.
Right. Employee gets back to work right away. We're not accelerating degenerative changes. We're keeping them whole and intact. Yeah, a lot of upside there.
Lots of upside. What anything where you're like, okay, this person or this thing's not a candidate, either body part or a type of person. I don't know if it's different blood types or anything that doesn't catch as well. Anything that are like no-goes.
Yeah, so we do have a good, fair, and poor candidacy grading. Everyone goes through that. We got data on 100,000 patients in our registry. It's the world's largest registry on these. And it's become a neural network. So it's always being updated and learning better. And so a poor candidate might be someone with, like your knee, multiple traumatic ligament injuries, fully retracted rotator cuff tears, um, uh, probably a fully retracted Achilles tendon.
Ugh.
Sometimes those just need surgery, right? That's the best thing. But so we don't treat poor candidates. And so we tell them right up front. That's why it's good to make this free, because sometimes that gets around the water cooler. Oh,
Sure.
there's a candidacy grading. They're going to just tell me I'm poor. I'm going to skip and go right to surgery. So again, the incentives help with that. But and then, we have a whole other guardrail there. If you're a good or fair candidate, let's say you did tweak your knee 6 months ago, but it's not debilitating, wasn't traumatic like your original injury, and you came to us because you're like, hey, I got this benefit, all these athletes are getting it done, I'm gonna go get it done. But our first question would be, hey, Lester, did you do physical therapy on that yet? No. That's where we're going to start. We want to do the least invasive, least expensive thing first. So about 30 or 40% of people go that route first. And about 30 or 40% of those people end up not needing us. And that's great. That's great for everyone. Then we use a different guardrail because we want to avoid surgeries, not just reduce costs or not just push people to conservative care, because that's not going to work for everybody. We use something from Optum that orthopedic surgeons have to use to confirm that surgery would be the next step. And so we put all that data in there too, because when we report back to the employer at the end of the year, here's the surgeries avoided. The first question is, how do you know they avoided surgery? Now we have a third-party evidence-based tool that said, yes, you did all these conservative things. Yup, surgery would have been the next step. So we have multiple guardrails to make sure we're intervening on the right people at the right time.
And well, that's really interesting because again, it's funny when I sometimes will get ROI reports on like even a telemedicine thing, right? It's like, oh, we produced a 28,000 to 1 ROI. And you're like, how do they do that? Like we asked people what they would do otherwise, and they said they would have gone to the emergency room. I'm like, okay, this is actually has true evidence. Like, did you do this? Did you do this? Did you do this? And I'm assuming that that's what they would have done when they tried to pre-auth. That's what the tool that they would use to try to pre-auth something for medical necessity. Like, hey, is this necessary? Well, yeah, we've already tried all of this other stuff.
Exactly. Right.
Yeah, that's really interesting. So let's talk about successes. Give me a couple patients that you're like, maybe different body parts. What were they struggling with before? And like, if you have any of those details, I think that's fascinating.
Yeah. Yeah, we see a lot of people who are on their way to a knee replacement, and that's being recommended at younger and younger ages. And so people will put it off because they know these body parts, especially if you're younger, wear out faster. So you're going to need a second surgery. Sometimes surgeons even say, you're too young. We don't want to do this twice. We only want to do it once. And so there's a lot of people who stop exercising, stop walking the dog, stop, doing activities with their families, and we see that a lot, who then get treated and now are back to doing their life, back to being active. And I'm not talking about CrossFit and marathons or triathlons, but just back to living a normal, healthy life. Cops and firemen, they're all hurt. They get hurt in the line of duty, and they work through it. We treat them all the time, and they get back to working out and being back on the rig, and and they love that. The spine with my friend I told you about, I've got it going in my neck, same thing. Um, it- just again, because I don't treat those patients necessarily, I don't see the before, during, and after necessarily, but I can tell you that, again, in our registry data, we track pain, function, and overall improvement, and it all gets better and is, available for everyone to look at. I'll use our knee data. When we look at the knee data, that cohort's got about 24,000 patients in it. People's pain drops from time zero, right? That's the day before the treatment, to 30 days later, 45% decrease in pain.
Wow.
Similar in function and overall improvement. Those are the three metrics we follow by body part, and it's pretty consistent by body part like that.
Man, and that's day 3 post-surgery. That's just when the pain starts, because that's when your anesthetics let wear off. I mean, I remember that day specifically when the local ran off, and now you're like, "Oh my god."
And the good thing is, because it gets better so quick pain-wise, you don't leave with 30 days worth of opiates. You might get 5 days worth. Most people handle the discomfort with Tylenol, but the thing to remember is 10% of people who have an orthopedic surgery will get addicted. And I'm not talking like walking around on the streets jonesing looking for another pill. But
Sure.
what addiction looks like is like they took the pills for 5 days and then they're feeling okay, and then on day 10 they're a little sore. So they took them for a couple days. But here's where it hits the plan. They end up going to the doctor because now they have insomnia or they have anxiety, and it's un no one thinks about that as addictive withdrawal. It's another thing. And so, a few days later, they take a couple pills and they feel better again, but this cycle continues. And so that's what addiction looks like as well.
And that's a slippery slope because, I mean, as we've seen with the stats, right? That's and I know people who are affected, personally, and it's like those aren't people, to your point, that were out, recreationally trying to catch a fix. These are people that something happened, and then all of a sudden, addiction is addiction, and they went down a bad route.
Yeah.
Um, any kids? How far down the spectrum do we go?
Well, because, cheerleaders and mostly girls, but certainly boys playing soccer tear their ACL. And so we've seen our fair share of adolescents, teens. I can think of my buddy who brought his 14-year-old son who had what's called an osteochondral defect. It's like a dent into the bone of the femur. And the cartilage, the bone, it was all dented in. And the doc's like, we'll watch it. What's it going to do? Get better by itself?
Yeah.
So he came to us, son's 22, graduating from college, been playing soccer with no problems. But we treated him when he was 14, addressed that osteochondral defect using his own cells.
That's amazing. That's
So yeah,
amazing.
we do see that.
So, Mark, if the audience being employers and advisors, what's something that you recommend them doing? Is this, hey, look at your health plan data, or is this something that's like, look, because you're gonna pay for this anyway, whether it's now or tomorrow, this is like, just go ahead and do it. Like, what's kind of like someone's next step that they're hearing this and they're like, man, this sounds intriguing. What do they do next?
The next best thing to do is really, let's just look at some data. We get claims data from last year, looking at all the ortho surgeries. We give people the CPT codes for the surgeon. This is the professional fee. We use healthcare blue book data to get the all-in costs. We crunch those numbers with our tool, and we give them an impact study. Like, here's what you paid, here's all the surgeries you had, here's what you could save, here's what the recovery and downtime look like. Give us a zip code census, we'll do the geo map, show you where the clinics are in relation to your members, and now you've got actionable data. And some people are like, hey, like you said, the 100-year flood's coming, right? It's
Right.
not, it's not gonna not happen. This just might be the good year that you're experiencing, but that doesn't mean it's gonna continue. The other thing I like to do with that, once they add this to the plan, is let's go retroactive 12 to 24 months and look at the high utilizers that are getting steroid injections, going to PT all the time, because that might hit the plan this year too. So if you're a July 1st start, hey, on July 2nd, we can be talking to your members who are already high utilizers and catch all that stuff early. So, there's definitely some advisors and employers that are proactive, that are looking at that like this. Literally before our call, I'm working with a manufacturer in Michigan, and the head of HR runs their plan. They don't have a broker. And she's been doing all this herself and is asking the right questions, the great questions. And so they're going to implement this, I think, sooner rather than later, because she knows they're going to pay for it somewhere.
And it's not something you got to wait to an effective date. You could put it in whenever. Yeah.
Put it in whenever. And that's great, because then it gets a little spotlight and it's not more of the
last page after the 45 minutes open enrollment meeting. Yeah.
Right.
I see that. Mark, if somebody wanted to get a hold of you, learn more, whatnot, where does somebody get some more information or get in contact with you?
Yeah, my email. I'm on LinkedIn. You can find me there, Mark Testa, DC. You can reach me on my email, mtesta@regenexx.com. Those are probably the best, easiest places, and glad to share all that information we talked about today. We got case studies. We've got cost savings analysis. We've got annual scorecards from employers that are de-identified. We've got a lot of data that makes the point.
Awesome. Well, thank you for sharing this. We've been saying this. I gotta get off my rear end and get these implemented into our plans too, because this makes a lot of sense. And the other thing I was thinking about is these on-site health centers, right? Because that's something that makes sense. So I was thinking about that as well. But so we'll pop your contact information in the show notes and all of that. And man, it was interesting to hear. I think the big takeaway I did is if it's a musculoskeletal, it could work. I wouldn't have ever thought that this was a potential spine conversation and all of that. I figured, elbows, shoulders, knees kind of stuff, but I don't know that I put the back on there. So that was pretty amazing.
Yeah, it's great. And it's every industry, blue collar, white collar, you name it. Nobody's immune to getting hurt or having pain.
No, I'm looking at construction workers out there doing the real job, and I'm sitting here with the one that my back is a little stiff today. So, go figure.
Yeah.
Well, Mark, thanks for being a guest on Impact Healthcare. Thanks for leading the charge. And, quite honestly, thank you for, seeing the issue, treating patients, and then coming over here to the delivery side, let's call it, to help fix this, because it's a big issue. So thanks a lot.
Thank you, Lester. I appreciate that.
Awesome. Well, if you got value out of this, and if you're like me and you learned a couple of things, hit share, send this to people you don't that need to hear it, whether it's somebody who is dealing with their own set of pains, or if any advisors out there, this is definitely a conversation that with MSK costs leading the top 5 cost on everything, this is a no-brainer. So thanks to our guest, Mark, and thank you everybody for tuning in to another episode of Impact Healthcare. We'll see you soon.
You've been listening to Impact Healthcare, people and strategies that are disrupting the health benefits industry with Lester Morales. Remember, the journey to getting 20% savings on your healthcare benefits starts with total transparency. Remember to subscribe to the Impact Healthcare podcast on iTunes or wherever you get your podcasts.